here, neither is Chris Jackson, but this is really a group of people who really works very hard, Dario as well, to start this movement. Thank you very much.
Thank you again. Dario Trapani, medical oncologist from the European Institute of Oncology in Milan.
Yeah, thanks again. I mean, it's really great to see you here. We were concerned, I really echo the next, that the room was not really going to be so full, but it's packed, so I'm really excited to see all of you here. And today what I want to present is really what's the European landscape in which we would like to, at this point, implement the common sense oncology principles, if this is like a favorable context, and where we can start from, and what's the landscape we are going to face, where the common sense oncology from Spain is going to spread across the Europe. That's of course the objective of this meeting, and of course for the next steps. So in particular, it's really great to stay here at Waldebron for the first time. I have never been here, but of course this is an institution that means a lot for the international community, and in general the Spanish community of oncologists has done a lot for the advancement of cancer treatment. So I'm really excited to be here with you, with the Spanish community, and broadly, because I see in the room you are from everywhere from Europe. So really thanks for inviting us. And I start of course from the principles of the common sense that are from the published manifesto. They really display what are the goals and what are the guiding principles that we would like to pursue. And I want to give a sense on how we can contextualize, and if this is possible, in the European context. In particular, as you see, and these are the updated data from the OECD that maps, the status quo of policy and access in Europe and capacity for cancer care and broadly for healthcare, you see that Europe is really a region committed to public health, and in particular for universal healthcare. So if you are importing, of course, such like a principle, CSO principles in Europe, it's because it's a very permissive environment in which as a community we commit with the tax-based contribution to cover all the population. Of course, with disparities in Europe you will see this, but more or less we are committed to cover all the people with the more or less public systems under universal health coverage attitudes. And this is really displayed across all the European countries, in which you see that out-of-pocket expenditure generally for healthcare is really small. It's generally below 10%. That's definitely a much better metrics than other parts of the world, definitely other high-income countries and regions. Europe is definitely an example in that. Of course, there exists a lot of complexity and normative diversity across the Union in a way, of course, in which every country is decided, because we're a union, but we are also several countries. But in general, we are really all together, we share this commitment for UHC, and this includes usually cancer treatments. It's also, and this Vishal also mentioned this, it's also the case that in Europe, we invest a substantial part of our budget, of course, for healthcare and for cancer care, but we don't invest too much. And so if you see the way in which we invest, it's definitely efficient. You see that usually the health outcomes are not really related to how we invest in absolute terms and relative terms. We are above, of course, a certain threshold, but this commitment for population health and for access is definitely something that makes the population health improvement tangible, because of course we invest on everyone in an efficient way. And of course, if you want to invest efficiently in the European Union, you need to communicate the evidence behind the value, and you need to understand what value means, what are the priorities, of course, for health interventions to optimize and to be implemented. And at least in Europe, this is something that we do pretty well. Of course, there is a lot of space to improve and to harmonize the region, because we're a union, but again, we are single countries. But if you see, of course, what are the range in which we invest public money in terms of absolute GDP and in terms of percentage, of GDP, it's definitely below other countries in the world, the high-income countries. And our champion, formula is really to cover as much as possible and protect the vulnerable population. And in fact, I just reported this amazing editorial in which is very well displayed that it's not how much you invest, but it's what you invest. And if such an investment is value-driven and oriented to the access, of course, you protect population health benefit. That is why in Europe we observe some of the best health outcomes for cancer care. Like Spain is the #1 in the world, together with some Asian countries like Japan, where some of the best health outcomes in the world because of this commitment for value and population health. And in general, if you see how Europe is organized at this point, is really organized under growing leadership that's going to make everything very centralized and very homogeneous, because of course, again, it's a mix of countries. And if you see that in Europe we have this privilege now, it's a couple of years now that we have a cancer plan. So we have a budget that a single country is not really much. We saw, who follows this politics and economics, that recently one European a report for economics says that we should invest 8 times more to be like appealing worldwide in terms of sustainability and economic growth. But you see that we invest something at least as one community to invest in cancer control, and this cancer control is really person-centric and is devoted to capture the experience of the patients and to improve quality of life. There is a commitment in Europe in a project called the Smart Care that's embedded within the national cancer, the regional cancer plan, the European Europe Beating Cancer plan, in which there is a strongest focus on quality of life reporting and improvement through a lived experience approach. That's something also the global organization, including WHO, is really investing a lot to not only report the data on the outcomes, how long people survive, but also to understand what is the experience within the health system and also how this experience translates in quality of life change. Of course, if there is such a high level endorsement for quality of life improvement, is there where we can frame our initiative, because we are of course patient-centric, person-centric, where quality of life plays like a bigger role. And you see that also the European pharmaceutical strategy actually is interesting, because Europe has one strategy for the pharmaceutical companies, and this includes a big part for cancer control, for cancer medicines, that is like an investment and a prioritization within specific programs to invest on the unmet needs. And these unmet needs are really defined as where the companies don't usually invest. Of course, this is policy, so we need to understand how to frame, and I think that an initiative and a movement like the Common Sense can inform, and that's what makes our movement, our European Union, permissive for the common sense, because in the laws, in the regulation and normative environment, this is already there, and we know that we can definitely expand the common sense with initiative and implement the tools, because this European Union needs the tool, of course, to make this reality in the clinical practice, and the culture, I think, is there, otherwise this room was not really packed. And also, of course, we criticize a lot, our European Union, of course, EMA makes some of the decisions on the drugs, and the first one on top, really, when these drugs are not great, but broadly approved and hyped. But in the regulations on how we should approve the drugs is reported that we should prioritize patient-centric outcomes. And in particular, all the EMA rules on how we should approve the drugs really put the strongest focus. This is like how European Union regulations are framed on the overall survival. And also to have a proof or a signal that overall survival is not harmed. So OU is contributing or is collaborating with EMA for the drug approval as scientific advisors, or SAG, so as advisors of the regulatory agency in Europe. You will always see that usually the EMA is very strong in providing and asking for the overall survival data, updates, subgroup analysis is very strong. And I think in the last 5 years, this has really defined the big difference with other regulatory agencies, in particular with the US, in which Europe has put also on not proclaimed subgroup analysis because of signals on the overall survival. There is commitment, and there is this way portrayed at least in the regulations, and of course we see this is translated usually, but not necessarily every time, in how we approve the drugs. There is of course also a note on the surrogate or intermediate, proved or unproved endpoints of PFS is of course the chief, because it's a widespread use. Many clinical trials, of course, submitted to EMA will be powered for PFS, and of course regulators have to deal with such like an improvement, and if this is tangible or huge, of course they have to take into account. And so there is like specific note and paragraph on PFS, but usually provided that you don't have detriment on overall survival, and with the specific notes on quality of life. The regulation is moving toward improvement of quality of life, empowering clinical trial for quality of life, but I think we're not yet there. But that's definitely the direction that us as a community, and based on the common sense, we should probably portray as a pathway for improvement of the population health outcomes through patient-centric outcomes improvement. This is just a landscape of recent drug approvals in Europe, and you will see here that most of the drugs that we have approved, of course, as we know, they were based on surrogate or not necessarily proved. This is DFS and PFS endpoints. Some of them were based on direct endpoints, and most of them in the metastatic setting had, in the curative, sorry, I think that's a mistake there. In the, below is 4 and 5 score. So in the curative setting, most of these drugs are high score A and B, but in the metastatic setting, below should be 4 and 5, only a half of them really portends benefit. It doesn't mean that we have approved 50% of the drugs that have low value, and usually we're uptaken in our countries these drugs and implemented in clinical practice, investing on low value. And of course, we don't really know how much we have invested. I will show some figures, but of course it's like a lot of money that we're investing in something that's not really high value. According to standardized value metrics, and MCPS is of course the gold standard at this point, and you can show this here, showing our commitment as a society to improve such a scale. I also provided some metrics on the accelerated approval, and you see that everything is accelerated and fast track is not definitely associated with intrinsic value of the drug. Every fast track that can encompass around 30 to 50% of all the approved drugs is not because it pertains more benefit, it's for something else. Sometimes it's for some orphan designation, some rare tumors, you can have these. Sometimes it's other type of agreements and surrogate endpoints providing some benefit. But in general, there is just no correlation between what we fast track as regulators through adaptive or accelerated pathway for regulatory approval and the ultimate outcome. And what's interesting, and this is really a problem in Europe more than US, that once we approve, it's very hard to disinvest in these drugs. We don't remove disapproval, even when the overall survival data come and the overall survival is not improved or even like not necessarily increased, and we only withdraw drugs where there is a clear detriment on the outcome. Usually, I mean, we don't have, luckily, but of course we can have just not proof of this overall survival impact. That's the ultimate outcome. So there is a focus, of course, on overall survival, but then we don't have a regulation in place to disengage from the low value when you have the ultimate place, like the ultimate data, that this is not really increasing patient-centric outcomes. And that's where, as a common sense community, we should definitely work toward to disinvest in the low value, of course, of the public money in the European context. This is just like how European Union reimburse the drugs, and this, at this point, the HTA agencies make national decisions. Every country in Europe makes separate decisions at this point, and they're really spread across very diverse timing from the EMA approval to the national uptake, and also the rules that govern this kind of uptake and decision making is very different across the countries. It's interesting that Germany, they don't really negotiate any price. Everything is approved from EMA in one day is approved in Germany because they have a different mechanism, to update the drug, a different way to negotiate and implement the drugs. I know someone's from Germany, but it's just like probably the most the fastest, in 3 days we can have the drug in place. But then they kind of start a negotiation. They have a sort of value-based system, but they have a system that's mixed, private and public. So of course it's a little bit more complicated. But all the other countries really take much time. And this is like, Belgium, they just reimburse less than a half, probably higher value drugs, but they really take too much. So probably, and Belgium has like a very good system in place, or the Netherlands, they have an amazing system that's value driven, but probably a little bit low. Because of course, if the drugs that are high valuable are not prioritized in the evaluation of the dossier from the EMA to the national regulators, that's the problem. We don't make any decision that's value-based. And so this is really well displayed in such a delay because there is no correlation between clinical benefit and the time from the EMA approval to the national uptake, and that's a big problem. In Italy, we were trying to kind of fast track, according to the MCBS score, the national negotiation for the prices, and in some countries there are elements of value-based agreement, like managed entry agreement, pay by performance, risk-based agreement, and financial agreements, but still probably is not necessarily enough to prioritize the good drugs. And it's also very interesting that usually who fast tracks the drugs is the countries that are wealthy, like Germany, France, and Spain. They can definitely get the drug because they're more flexible budget. They can definitely put more money on these drugs. And it's interesting when the data come from the big companies. Actually, it's very interesting because much of the drug development is probably done by the biotech, but when a big company presents like a very good report on clinical trial of a phase 3 for some regions, and of course there's a lot of lobby here, they approve nationally in a shorter time. And this is something that we should pose and reflect as a community because that's of course another part of the problem. But it's interesting because next year in Europe something will change. We will have this clinical joint assessment. So all the clinical assessment will happen in a centralized. Italy is one of the leads of this initiative together with Ireland. And we will have a joint assessment, and probably if we are able as a community to push to have value-based metrics or priority setting for the evaluation in this joint assessment, it's probably the way we should push the agenda to make sure that this kind of national discrepancy don't exist, and also that everything is prioritized is because of the value, not because of GDP or because of some kind of the lobby that we can't control, but it's not value, as you can understand, for patients. Of course, disparity in the access, and I'm almost done, disparity in the access in Europe exists, and this is very well recognized by the European Cancer Control Plan. It's very well recognized by the Commission, and in fact, they just launched a disparity registry that is supposed first to identify the different cancer outcome nationwide, and also to understand which are the determinants, and some of them will be, of course, different access to treatments. This graph, of course, displays the percentage of the drugs that are approved nationwide and reimbursed in comparison with EMA approved drugs. And you see there is, of course, a spectrum that is usually a function of the country GDP. We know that, of course, Europe is not one, but it's definitely like separated countries. We have a southern part, we have an eastern part that are very diverse, in which we have a different way in which the cancer agenda is prioritized and invested. But overall, of course, the big difference is GDP of the countries and the possibility to invest on the very expensive drugs when you don't have enough funding, and these drugs are very expensive. There is no way you can uptake the high-value drugs. And the very clear example is immunotherapy. You know, and in the past it was trastuzumab for breast cancer. Like 10 years after the approval, it's not definitely accessible like in all the countries, and definitely Europe. This has been a problem up to a few years ago, and that's of course like an old drug now. You know, like we think of this as the old story for breast cancer treatment, and we have to in some way. So we have a registry now to track these trends and to understand which are the determinants of the different outcomes, and that's where again we should frame our CSO attitude and movement to communicate the value, to make sure the countries make the decision based on the value and not based on other type of lobbies that I've showed you before. And I think common sense is really like the way as principle to shape such a discussion with regulators and decision makers within such a disparity context. So just to wrap up, I think that European Union, it really represents the optimal context to implement CSO movements, culture and goals, and also of course the tools, because we are very permissive. Our regulations in the European Union, our European Cancer Control Plan, our pharmaceutical policy is really pushing us toward the high value, but of course we need to fight against some kind of oncologist attitude. We were mentioning before some experts. We need to realign everything what is to value that is perceived, conceived, communicated, and implemented in a person-centric manner, and I think that at this point, CSO is the movement to make such a change. Thank you.